Good afternoon, everybody. My name is Chris Ray, and it's my pleasure to share our family's SCN2A journey with you today. My husband, Justin, and I live in Shawnee, Kansas, and that's a suburb of Kansas City, with our daughter, Maddie, who is my SCN2A kiddo. And Maddie is going to be turning 16 this fall. Hey. She is a beautiful teenage mess, kind of a combo of an outrageous goofball and a hormonal monster from hell. I'm just going to start with just kind of her personality, but she loves music. She loves anything from the Laurie Berkner Band, silly children folk songs, to now instrumental jazz, which is very calming for me, so that's nice. She also loves playing in the water. When I tried to prompt her the other day on her personal support plan, what do you want to do? What kind of job do you want when you finish school, Maddie? Firefighter. It's like, spray fire with hose. It's like, didn't have the heart to tell her that her heat intolerance might be a problem. So Maddie also loves washi tape. Those of you that know me have seen lots and lots of pictures of washi tape on my Facebook page. She likes to unravel it for stress relief, and then she just tapes anything and everything she can get her hands on, including herself. So I have it on auto ship with Amazon. Must have bulk orders with that. Things that Maddie doesn't like, she doesn't like loud places, which is why she's not here with me this week. I would have loved to have brought her here so you guys could meet her. And my husband is staying home with her. This would have been incredibly overwhelming for her. She would not have done very well. So you'll just have to hook up with me on Facebook to meet her personally. I share a lot of anecdotes that way. But other things she doesn't like: waiting for anything and open doors. All doors must be shut unless it's the closet door, because that's where the washi tape is. So a little bit of background. Next slide, or I'm going to try it. Hang on. It's working. Yay. So I was 40 when I found myself pregnant with Maddie. So due to my age, it was considered a high-risk pregnancy. So there was a lot of testing that happened, the amniocentesis and some ultrasounds, and there were no red flags initially. And it wasn't until 2.5 weeks before my due date that I was feeling some weird things. I went into the hospital and found out I had preeclampsia, and it was pretty severe. So I went through a very long and traumatic labor, I think almost 20 hours. Multiple epidural doses, very stressful, and Maddie came out with a cord wrapped around her neck. Fortunately, after a few days, we recovered and we were released to go home. After that, Maddie was really what I thought was a very happy, healthy, beautiful baby. We didn't see any signs of problems until maybe she was about a year old, and just started seeing some delays in developmental milestones, like she was really slow to walk, and I don't think she ever crawled. And then the talking just really never came. There was maybe some mamas and dadas and things like that, but really, really slow. So the other thing that really kind of caught my attention is Maddie would just constantly rock her head back and forth. Even when I laid her down to sleep, it never stopped. And in fact, it probably kept her awake because she never slept either. She still doesn't sleep really great. She's not rocking in her sleep anymore. Her body constantly rocks throughout the day, but she's instead taken to ripping up her favorite books and shredding the pages and shoving them behind her headboard, or scratching the paint off her walls in the middle of the night and then trying to say it's because she's making a goat, but to like blame all of this shredded paper on, I don't know, maybe. So at age 2, oh my gosh, age 2, Maddie was diagnosed with severe autism, intellectual and developmental disabilities. So we got her into intensive therapy, all of the things, ABA, physical therapy, occupational therapy, speech therapy. She does have limited verbal speech, but she's just very repetitive, repeats a lot of words and phrases. She's also, if you want to go to the next slide, or I'll just go to the next slide. Self-service. These are some of the things that she has dealt with over the progression of her disease. So chronic constipation, now diarrhea, urine retention. She used to hold her pee for like 20 hours straight on average. Still really struggles going to the bathroom. She was diagnosed with early puberty at age 7. Now she has hyperandrogenism, which is too many male hormones. So a lot of hormone imbalances. She's got CVI, she's got vision loss. She experiences crippling anxiety and OCD. Like I said, needs to have all the doors shut, lots of other things that are very problematic. Then with all of that rapid growth and her low muscle tone, she started developing a kyphosis. So her upper back is very rounded. Her gait is now crouched, and it's very painful. All of that is for her. So it's triggering for her, and it's reduced her mobility significantly. She used to play on the playground and walk with me. Now I need to take her around in a wheelchair. So it's hard to get her out. When we try to walk, she'll drop a lot. She gets very deep, dark bruises on her knees from doing that. She's also heat intolerant. And then when she was about 12, she started experiencing these rage episodes. She just out of nowhere starts screaming, running through the house, flailing, throwing herself on the ground, slamming her head to the floor, hitting herself in the face. And I was at my wit's end. That was actually the first time we ever went to a neurologist. So the neurologist that we went to at the time listened to us. He's like, you know what? I think this is more than just autism. So that was the first time we ran genetic testing. And so we didn't find out Maddie had SCN2A until she was almost 13. After that, we ended up transferring our care to Dr. Kaufman, who's here today, and he's going to be speaking in just a little bit on the subject of autonomic dysfunction, which he diagnosed Maddie with. We have determined that that is the reason behind her rage episodes, that she has a hyperactive fight or flight. So everything is considered as a threat. Overstimulation, overheating, discomfort, even a stuffy nose. All of those things are going to set her off. She's always in a hypertensive blood pressure range. So we just have to be very careful to regulate her environment because she doesn't do a great job self-regulating. So with all of that, we also got connected with FamilieSCN2A Foundation, which has been an amazing support for us. The board, Leah and Michelle and Carla have been so great, and just all the families. It's been so wonderful to share with you and to learn from you. I don't think I could have gone through this without you. I've just been on this mission to learn and to educate everybody in Maddie's life on SCN2A. And it's amazing now, where I used to have the feeling of a lot of judgment, making excuses for her behaviors, like her urine retention was just behavior. We needed to train her better. Now all our caretakers, our physicians, our teachers, they're all on the same page. And they're reaching out on their own initiative to each other to collaborate and try to brainstorm and find better care plans for Madison. Also, we learned through the help of Dr. Kaufman that a lot of the meds that we were trying to give her to help calm her because of her sodium channel loss of function were creating more problems, and like significant side effects that pharmaceutical genetic testing did not tell us was going to happen. Like the SSRIs we tried, no, didn't help, but they landed her in the ER. So now we know what to avoid. And I would just say that, to the families out there that think that their kids just have autism, look further. Like, never give up, because it's never too late. We got our diagnosis very late, but it was a game changer for us. Has she, has her quality of life improved? Not a lot, but at least we know what to do to maintain and to keep things from getting worse. So we have plans in place. The school has been a tremendous help for us. And I would just say that the other thing that's important for everybody in here that I've learned, because I'm almost 60, is take time for yourself. Like those waiver services, if you're not on them, get on them. You need to get help. My health has started to decline. I waited too long probably, but I've learned that lesson. I've hired a personal care assistant for Madison, and she's helping me get out, take care of myself. And my husband and I are having dates every weekend, which we haven't done in years. It's literally saved our marriage. So yeah, thank you. But, I also want to say, those of you who have loss of function kiddos, and I know my time is up, that, don't feel like your needs are less important than gain of function. Like, no one is more or less important in this fight. We're all warriors in this together. Like, our loss of function kids may not have an immediate threat to have their life snatched from them like some of our other kids do, but it is taking their life. Like, it's stealing their joy. It's robbing them of the peace and the freedom from a life that's dependent completely on other people. So like I said, this is all for one. Like, we're all in this together, and just, speak up when you need help. Thank you guys for letting me share my journey.
Thank you so much, Chris. I really appreciate that. We're going to go into some other developments in understanding autism and intellectual disability associated with SCN2A. And we're going to bring to the stage Natasha Ludwig, Dr. Ludwig from the Kennedy Krieger Institute at Johns Hopkins.
Can you advance the slide, please? All right. And so to advance, I just push this button. Good luck. Oh, no. All right. All right. Thank you. All right. Hi, everyone. I'm so happy to be here today to talk about autism and intellectual disability associated with SCN2A. A little bit about myself. I'm a pediatric neuropsychologist at Kennedy Krieger, and I recently got the privilege of becoming the attending neuropsychologist in our synaptopathies clinic. So I'm starting to see a lot more kids with SCN2A, and I'm just so excited to be here and to meet you all. All right, so overview of my talk today, I'm going to talk about genetic conditions in general and behavioral disorders, and then SCN2A as an etiology of ID and ASD. And then I'm going to talk about intellectual disability and autism more broadly, and then a little bit about some measurement issues that we face in our discipline. All right, so diagnosis of genetic conditions has increased rapidly, particularly genetic conditions associated with intellectual disability. So you can see here on this graph, it's a graph over time of the different genetic conditions that have been identified associated with intellectual disability. So behavioral phenotyping is really important in understanding the clinical presentation of genetic conditions. So I want to talk a little bit about the definition of behavioral phenotype because I'm going to use it a lot throughout my talk. So behavioral phenotype is the characteristic cognitive, functional, behavioral, and psychiatric pattern that's typical of a disorder. And so it's basically a heightened probability that individuals with a genetic condition will show certain behavioral or developmental sequelae related to that syndrome. Okay, and then this term behavioral phenotyping is basically collecting information about the behavioral phenotype. So genetic conditions, particularly those that impact brain development, present with variable neurodevelopmental phenotypes. So you can see here's some examples of different neurogenetic conditions. And there's a spectrum of, level of intellectual functioning. There's a spectrum of, comorbid medical pieces, right? Like seizures, social impairments, anxiety, psychosis. These are all aspects of the behavioral phenotype. And it's important to understand that so we know what to expect when a child is diagnosed with a certain genetic condition. So intellectual disability and ASD are part of the behavioral phenotype of SCN2A, right? So these are behavioral disorders. So what that means is that these diagnoses are based on what's observed by a clinician, okay? There's no objective test of a diagnosis, right? So there's no blood test for autism or intellectual disability. Clinicians make clinical judgments based off of what they see in cognitive and diagnostic testing. And at present, the etiology or the cause of autism or intellectual disability, it doesn't matter in making that behavioral diagnosis, okay? But the cause is still really important in managing that child's care, right? So both are really important to know. All right, but so then if we have the genetic diagnosis, why do we need that behavioral diagnosis as well? Well, the main reason is for communication purposes. So we can further specify a child's needs within a certain genetic condition. And then behavioral phenotypes of genetic conditions are really not fully understood at this point. And so, hello? Okay. So saying a child who has SCN2A, it can be helpful. We kind of know what comes along with that. We're still learning more, right? But it doesn't fully explain what a child might need. When we start to add some of these behavioral diagnoses, they start to accomplish this way of like communicating a little bit more about what that child might need. Of course, there's still a lot of variability in terms of intellectual disability and autism itself, but once we start to get, the genetic diagnosis, once we get these behavioral diagnostic labels, it can start to help refine exactly what a child might need in terms of their clinical care. So that's how it can be helpful. Also, attainment of services, right? So sometimes we need to have that behavioral diagnosis in order to get, those state services or whatever, ABA services, whatever it might be. And then also behavioral diagnoses are important in terms of understanding the behavioral phenotype of these newly discovered rare neurogenetic conditions, right? So with like SCN2A, for example, knowing the prevalence of intellectual disability, knowing the prevalence of autism can really help understand what to expect, right, when a child is diagnosed with a genetic difference. All right, so I'm going to talk now a little bit about the genetic, so SCN2A as an etiology of ID and ASD. All right, so we know that seizures are pretty common in SCN2A, right? But we also know from case reports, case series, cohort studies that ID and ASD are also really highly prevalent and make up a big part of this disorder and the lived experience of this disorder. So we know that SCN2A is actually one of the most common monogenic or single gene sources of autism spectrum disorder. So pathogenic variants of SCN2A are identified in 0.3% of ASD cases. Now, that seems like it's really small, right? But when you think about how rare SCN2A is as a condition, it's actually a pretty big component of what explains autism in the world, right? And we know that loss of function mutations in particular in the SCN2A gene are associated with autism rates of up to 50%. So this is really a big part of the disorder. And we know we have these two clinical phenotypes associated with the ID piece, and then one of them with the ASD piece. But of course, nothing is clear cut, right? You can have deviations from the norm, but we have this SCN2A associated autism and intellectual disability phenotype with earlier development that's generally unremarkable for about 6 months, followed by moderate motor delay and pronounced verbal delay, as well as seizures which can also impact, developmental progression and sometimes regression and skills as well. And then, of course, we have the more gain of function phenotype, which is the infantile epileptic encephalopathy, where development can really vary from moderate to profound global developmental delay or cognitive impairment. This is a really nice graph I wanted to show you all from a paper that came out looking at the different, some of the different rare genetic causes of autism and intellectual disability captured by the Safari group. And so this is looking at developmental milestones and delays in those milestones. So we have sitting, crawling, and walking, and then over to the right, we have communication, so single words and combined words. So the gray areas and the shade striped areas are indicating percent delay. So for SCN2A, I highlighted it here. For sitting, crawling, and walking, percent of the population with delays in those areas varies from about 45% to 65%. And then for single words and combined words, so communication, it's 83 to 86%. So it's a really, you can see there, that's really the area that is really significantly impacted. Of course, the motor pieces are impacted too, but overall, you can see that difference, right? There's even more impact to those communication pieces for SCN2A. I love this chart because you can also start to compare what does the early milestone development look like across the different, some of these other rare genetic disorders that contribute to autism and intellectual disability. So not much is known about the unique SCN2A ASD phenotype, but as we gather more and more information about other, these rare genetic variants that can contribute to ASD, and as these models are compared and contrasted, we can really start to identify okay, what does autism look like in SCN2A? So we really need more research, more behavioral phenotyping studies to really understand that, so that when a child is diagnosed with SCN2A and autism, to inform that diagnosis of what is ASD within SCN2A, that can be important as well. So more research is certainly needed. We certainly have some hunches though from parent information about what they're seeing in their children, right? So we do have a hunch that, ASD in children with SCN2A is more severe than the general population of autism. And then there's some other characteristics that are listed here. But, again, I think we need more behavioral phenotyping studies to really understand this, to support treatments. All right, so now I'm going to talk a little bit about intellectual disability more broadly. So ID has a new name. I wanted to let you guys know that you might start seeing this. So the DSM, which is the book that has all the behavioral disorders that psychologists and psychiatrists utilize, came out this spring, and they've changed the name of intellectual disability to intellectual developmental disorder. And the purpose of this is to just be more consistent with ICD-11. But they put intellectual disability in parentheses, so we can still use it. Don't worry. But I just wanted to let you guys know that you might start seeing IDD instead of ID more often. All right, so there are many etiologies of intellectual disability. There's environmental causes, non-genetic causes like alcoholic exposure in utero, for example, but there's also genetic causes. And so we know that in SCN2A, it's presumed to be sort of the etiology or the cause of intellectual disability in these individuals. All right, so quick summary of what intellectual disability is, right, based on our DSM. So this is, again, the book that psychologists use to make this diagnosis. So we really need deficits in intellectual functions, right? But we also need deficits in adaptive functioning or independent skills, right? And these need to occur in the early in development, right? So when people are children. But we also use these specificities or severity specifiers, right? Because even if a child has ID, there's a really broad range of functioning, right? And it's really important to know where a child falls because that's going to inform the kind of supports that they need. So it ranges from mild to profound. So, and these are really informed based on, not on IQ score, but on adaptive needs. So for mild presentations, these kids might need assistance to perform daily living skills like shopping or cooking and managing money. And then you have the profound category, which is like the child is more dependent on others for all aspects of physical care, health and safety, though they may participate. And so these can be really important in terms of further guiding care and treatment. All right, just wanted to make you guys aware of some other intellectual disability diagnoses you may see. So one is called global developmental delay, and this is essentially defined as having delayed development in multiple areas, okay? And so we think that a lot of children with global developmental delay will go on to develop intellectual disability, but not all of them do. So, you know, I want you all to be aware of this term and how, you know, we use it as psychologists. Oh, and it's really reserved for kids under age 5. I forget if I said that, but yeah. So once a child turns 5, we can start thinking about making that diagnosis of intellectual disability if appropriate. And then we have this diagnosis called unspecified intellectual disability. So this is one that I actually come across and utilize myself because it's really helpful for kids where you're uncertain if they meet criteria for intellectual disability over age 5. And so I see a lot of kids with rare genetic conditions that are associated with things like sensory impairments, like hearing and vision impairments, and severe motor impairments, where these standardized tests that we have are really not helpful ways in delineating whether a child is meeting that criteria for the intellectual disability. And so this is something that I'll use with especially younger kids who may have like cortical vision impairment, for example, and I'm really not sure the extent to which that is impacting their ability to show me their cognitive function. All right, so I'm going to talk a little bit about autism now, more generally. So we know that autism is categorized by deficits in 2 primary domains, right? So you're going to have impairments in social communication skills, and then also you're going to have the presence of repetitive behaviors. But of course, when we hear the term autism, we know that it's a huge spectrum, right? And there's all these other pieces that are part of the phenotype that are really important to identify, and because of treatment, right? We want to make sure that we're getting a child what they need. So various levels of intellectual functioning, various levels of adaptive functioning, and comorbid symptoms like ADHD, anxiety, right? Medical conditions. This is really a big piece of the SCN2A, right? So having epilepsy is another piece that adds to the phenotype. So all these other pieces also need to be acknowledged, but are not necessarily part of the actual diagnosis of autism. So other pieces of the ASD criteria that don't get much attention. So symptoms need to be present early in the developmental period. Symptoms need to cause clinically significant impairment. So just because you have a social deficit, if it's not really impacting your functioning, it doesn't qualify as disordered, right? And so the other piece here is that the diagnosis, the symptoms are not better explained by ID, right? So this is a big one. And it's one of the most challenging pieces that I face every day in my job. So there was a really awesome article that came out out by Audrey Thurm's group at NIH. And it's sort of a guide for clinicians and researchers about how to differentiate when autism is present in the context of intellectual disability. And so this is an awesome article. It came out in 2019. I would recommend it. And so the main take home is that really, when we're thinking about making a comorbid diagnosis of autism within intellectual disability, our social communication skills should be below what is expected for the general developmental level. So they should be really specifically impaired or weaker than overall development for the child. So intellectual disability is like our skills are sort of similarly developed. Of course, there's some variability there, right? But then autism is when our social communication impairments are significantly weaker than where the rest of our skills are generally falling, okay? Plus also the presence of restricted and repetitive patterns of behavior, that second symptom domain. But really those can be present in intellectual disability at this level. So really the one you got to pay attention to is the social communication deficit. Again, you can see this. This isn't that chart I showed you earlier, right? With the milestones. You can see this in the kids with SCN2A, that the language milestones are the ones that are most severely delayed compared to the motor. Again, of course, motor is also, we're seeing some impairment there, but I think this is one way that we're demonstrating the prevalence of autism in SCN2A through these data. All right, I want to take a few minutes just to talk about this term, profound autism. Okay, so this term is a term that has been proposed by the Lancet Commission. So was authored by a lot of important people in the world of autism, and it's an article about the future of care and clinical research. But there's a part of it that talks about this term, profound autism, and how perhaps we should start considering as a field to utilize this term, not as a diagnosis per se, but just as kind of a specifier in a way, or an administrative term, to really categorize this group of kids who are profoundly affected from an intellectual level, and then also in terms of their autism symptomatology. So the rationale for this is that they said, well, the current ways that we specify where a child is at beyond just the autism diagnosis, they're not used consistently, they're not so helpful. And then research and media are really focused on the less severe kids. And so we really need to pay attention and research these kids. They're underserved, they're left out of research, and they're left out of the media. And so people aren't really paying attention to their specific needs. They also identified that there's vastly different educational and long-term care needs that are needed for this population, right? So we need to be able to identify them early and get them served. And also, so the criteria. So they're basically saying that what profound autism means is these kids need 24-hour access to an adult who can care for them. They can't be left home alone, right? They need a lot of help with their basic adaptive needs. So the way that they've broken this down is like, okay, if their IQ is less than 50, and if they have very limited language, or both of these things, that kind of meets the criteria for profound autism. So this term is kind of controversial right now. So some people think that it's really important to have, and some people are like, no, why are we doing that? So Leah actually sent out a survey to the family. So thank you everyone who participated. We had 68 people respond, and you, the majority of you thought that, you were in favor of this recommendation to use this term, profound autism. Some of you also provided some qualitative responses. So I wanted to highlight some of the points that you all made. So this qualitative response was in favor of this term, and really gets at the idea that our research doesn't show the most severely affected kids, right? It's higher functioning or less severe, rather, kids, which really skews the public opinion about what autism looks like in this group, and the help that is needed and the supports that are needed for this group. Others were opposed to this. And so one person had said, the profound autism group is such a small group. So if we depart from kind of the broader autism, efforts and segregate ourselves, maybe our voice isn't going to be as loud, right? So maybe we should stick together. And then somebody had said that the cutoff was too narrow. So maybe individuals with an IQ above 50 still have significant impairments and still have really profound needs, right? And then the other theme that really evolved was more of a suggestion, right? So maybe we should, instead of having the criteria be IQ level and language level, we should really have it be based on level of support or level of need that these kids have in terms of making this specific category. So thank you all for this. Stay tuned, pay attention to what's going on with this term. I've definitely seen some grant applications already coming out saying, this is for profound autism. And so I think, be aware of this, and I'm interested to kind of see how this evolves as well. All right, in the last few seconds I'm going to talk a little bit about measure issues, which is a huge part of, my job and something I face every day. So going back to the way that Thurm and colleagues had suggested to diagnose autism with an intellectual disability, right? In order to do that, we need to understand where a child's cognitive level is, and we need to understand where their social communication levels are, right? But that's really hard in this group because for severely affected children, we just don't have the right measures to be able to do that and to quantify that. And so our gold standard autism diagnostic measures are really unable to distinguish autism from non-autism when a child's mental age is below 18 months. And so we use these tools to help inform our clinical judgment, and we're really left with not much here. And additionally, a lot of these tools are not validated in kids with sensory impairments like CVI, in kids with hearing impairments, with kids with severe motor impairments. Like literally, they don't even look at how these measures work in these kids. And so we're left with nothing, as clinicians to really understand and inform our clinical diagnostic decision-making. So it's a real problem in our field. And then beyond even the autism symptoms, how do we determine developmental level within intellectual disability, especially those who are severely affected? There's a term called profound intellectual and multiple disabilities that you may start hearing more about. And this basically is a term to define kids who have severe intellectual disability where standardized tests are really limited, okay? And these kids often have the motor, sensory, and language impairment. So a lot of our kids with neurogenetic conditions that are causing ID and autism kind of fall within this crowd. And so it's really something to be aware of. And we need to do better as clinicians and researchers in improving our measurement tools. This is just a quick schematic I've developed kind of to illustrate this problem, right? So we have severely affected children with developmental epileptic encephalopathy, so including SCN2A, right? We need adequate measures to inform patient care at the individual level, like right now, but we also need these tools to document natural history of the disorder so that we know what does it mean to have an SCN2A diagnosis? What does that look like, right? And then also for clinical trial readiness, because we need to know what treatment targets are important to patients and families. So for all these reasons, adequate measures are vital, but we have really limited ones because of these severe communication impairments, physical limitations, behavioral dysregulation that can all impact the validity of our measurement tools. And we need measures that can capture variability. So to delineate strengths and weaknesses on the individual level, but also we need measures that can capture change over time, right, in response to interventions like novel treatments. So this is something I'm really passionate about, and I'm really hoping that we can do better as a discipline and field. So how do we overcome this? Well, it's partnerships, right? So researchers, clinicians partnering with families and learning about what's important to them, right? What measures are working, what are not working, right? And what do you think is important to measure? We need people from industry and regulatory bodies all sitting at the table together to discuss these issues. Thank you to all the families who participated in the Inchstone project. This is something that we've been collecting data at this conference for, and is in the effort of doing better in terms of measurement and in terms of serving this group of children with SCN2A. And also what we learn here can be, we hope can be used for other rare neurogenetic conditions as well. So thank you so much to all you guys who participated, and thank you so much.
Thanks very much, Dr. Ludwig. Oh, this is great. We've got all the slides in one big PowerPoint now. So we're moving. We're moving so fast. We're faster than Dr. Kaufman. Dr. Keith Kaufman joins us from Children's Mercy Hospital in Kansas City, and he's going to tell us about autonomic dysfunction associated with SCN2A.
Okay, so we're going to talk about mostly everything outside of the central nervous system now, okay? You've heard a lot about brain. The rest of the nervous system controls most of the rest of the body, okay? So the autonomic nervous system is responsible for everything you see on this slide. Heart rate, heart contractility, respiratory drive, temperature regulation, moving your gut, emptying your bowels and bladder, sweating, blood vessel tone, so sort of the color of your skin tone, your arousal state, your sleep-wake cycles, and your response to pain. I can talk louder, okay? Show of hands, who has an SCN2A kid who has symptoms of or problems with these systems? Yeah. Who's been told we don't know why they happen? Okay, I'm here to tell you why. And now I have data, okay? So I've talked about this in the past and the criticism has been, well, there are no publications. Now there are data, okay? So there are three branches of the autonomic nervous system. The enteric nervous system, so that controls your gut from your esophagus all the way down to your rectum. Your sympathetic nervous system, so fight, flight, or freeze. You heard from Chris that when you have a kid who's constantly in a state of fight or flight, life is challenging. And then your parasympathetic nervous system, so rest and digest, right? I tell people there's two languages we speak, doctor and human, English, right? If I speak to you in doctor, you don't know what I'm saying, right? If I said the sympathetic nervous system, parasympathetic, fight or flight, rest and digest, you got that. Okay. So here is a public use diagram of the autonomic nervous system. So starting all the way up from the eyes, all the way down to the ovaries and genitalia. So Chris's discussion about Maddie's differences in precocious puberty and differences in androgen production. Yeah, that's part of the autonomic nervous system. Okay, heart, lung, liver, you got it. So the autonomic nervous system is not autonomous. We call it autonomic because you don't have any voluntary control over it. But the central nervous system, specifically the brain, plays a huge role in regulating the autonomic nervous system. So one of the big centers is the hypothalamus. So hypothalamus sits right in the center of the brain, and it is really control central for hunger, thirst, sleep-wake cycles, pain regulation, temperature, heart rate, blood pressure. Moving down to the middle of the brain, so creatively called the midbrain because it's in the middle of the brain. That's where your substantia nigra lives. So substantia nigra means black substance. Anatomists are not creative people, okay? That's where your dopamine cells live. So dopamine is heart rate, blood pressure, blood vessel tone, intestinal control, and reward circuitry, okay? And then your brainstem, also not creatively named. Your serotonin cells live there. So pain, mood, vomiting, sneezing, blood vessel tone, and then your medulla, heart rate, breathing, sneezing, vomiting, okay? So I've covered basically everything that was on that first slide, okay? So we know this is not an SCN2A specific paper, but we know through work that Dr. Berg, myself, and Dr. Deborah Gabler-Spirit published is that children with developmental epileptic encephalopathies have very high rates of parental reported autonomic symptomatology. So we found that symptoms were present in 81% of subjects, and that more critically, impairment in at least one functional domain of life was seen in 90% of these subjects. And the 6 domains we looked at were cardiac, respiratory, sweating, temperature, GI, and other. And other could be things like skin vascular tone, sleep-wake cycles, things of that nature. So we published this last December. And what is the direct evidence that autonomic dysfunction and sodium channelopathies, including SCN2A, exists? So looking at SUDEP, so sudden unexpected death in epilepsy. So well studied in the SCN1A population. And one patient in this study with SCN2A, what clinical neurologists look at for mechanisms and measures of autonomic dysfunction are heart rate variability, right? So our heart rates naturally go up and down, both while we're awake and we're asleep. In this cohort of individuals who died from SUDEP, the individual who had SCN2A who succumbed to SUDEP had the lowest heart rate variability while awake and the most extreme heart rate variability while asleep. And this was obtained by looking at video EEG records when EKG is being recorded. And this was published in Epilepsy back in 2018. And then published in 2021, looking at the genetic encephalopathy, epileptic encephalopathies that have increased risk of arrhythmia. So SCN2A patients likely had an increased risk of cardiac arrhythmias, and this was published in the Annals of Clinical Translational Neurology. And if you look at the fourth author, it's Brugada of Brugada syndrome, which we know is also an SCN-related cardiac arrhythmia. Furthermore, why in the world am I talking about the heart, right? SCN2A is a central nervous system disorder. The reason I'm talking about the heart is this paper that I came across that blew my mind. So some of you who are in the basic science world probably know this paper. It was looking at the molecular network underlying autism and congenital heart disease. So it was published, a huge group out of UCSF late last year in Cell Systems. And what they did was they took, so the scientists in the room, this was a Xenopus tropicalis model. For the non-scientists and parents, in a frog model, right? Dr. English, got it? Okay, so when you mutated in that model system, SCN2A, the frogs had significant malformations of both the heart and the central nervous system. Both the heart and the central nervous system when you modulate SCN2A. They go on further to talk about the fact that in the mature nervous system, SCN2A is not really expressed in the heart. But in the immature nervous system, developing nervous system, even in human, it is, okay? As a child neurologist, as a neurodevelopmentalist, and as an anatomist at my core, this makes sense to me, right? Embryologically speaking, heart and brain are midline structures. We know in the world of complex congenital heart disease that if you have a difference in heart structure, you're much more likely to have a difference in brain structure. And what this study implicates is maybe SCN2A plays a role in this. Okay. So that's the heart piece. Now we're going to get on to what we call the paroxysmal sympathetic hyperactivity piece. So these are events where kids, typically with encephalopathy from some cause or another, have really sudden, severe things that people think are seizures. They'll body temperature go up, they'll get a fast heart rate, they'll develop rapid breathing, they'll have high blood pressure, they'll sweat, they'll drool, they'll have irritability. Everything that you've heard about occurring in SCN2A kids, okay? So how did I get into SCN2A? So this is Ellie. I told Michelle I was a crier. So Ellie's how I got into SCN2A. I met Ellie 7 years ago. When she had one of these episodes bad enough that it broke her femur. And people had told Michelle, we don't know what this is. Ignore it. It's not seizure. Just deal with it. So I didn't like that answer. So that's how I started doing this. What's interesting is that there's more direct evidence. When you look at the neurotransmitters, dopamine and serotonin, in humans with SCN2A, a 10-year-old boy with delay autism, ataxia, epileptic encephalopathy with an SCN2A mutation. Guess what, people? Low levels of dopamine and serotonin metabolites. And when you replace the dopamine and serotonin, he got better. Okay. When you look at the family of inborn errors of neurotransmitter metabolism, so this is a sub-area expertise of mine, you can have genetic disorders that cause you not to make enough dopamine and serotonin. The symptoms of those disorders are developmental delay, hypotonia, dysautonomia, movement disorder, drooling, and irritability. This is not what I say, this is what the world experts, including Phil Pearl, who's chief of neurology at Boston Children's, published. Okay. So, in closing, patients with DEEs frequently have symptoms of autonomic dysfunction. We now have human data to indicate these symptoms are part of the SCN2 phenotype without question. We now need to look at the fact that there's an animal model that implicates SCN2A in the programming and formation of both the central nervous system and the heart, and understand that this should open new lines of investigation regarding the role of SCN2A within the autonomic nervous system. And that's it.
Thank you so much, Dr. Kaufman. I'm blown away by that. The heart. I mean, we know it's in the heart. Look at everybody in this room, of course, right? Now, we're pleased to have Dr. John Millichap, Northwestern, but not really Northwestern anymore. Are you going to talk about that a little bit more? It's
Yeah,
up
so-
there.
Yeah,
He's gone on his own. He's gone rogue, people.
Yeah, so my name's John Millichap. I'm a pediatric epileptologist in Chicago, and what he's referring to is I was at Lurie Children's, formerly Children's Memorial Hospital, that's affiliated with Northwestern Memorial Hospital for 12 years, and I've gone into private practice, but remain adjunct faculty at Northwestern for teaching and research. And I was asked to speak to you today about epilepsy syndromes and EEG patterns associated with SCN2A in 15 minutes, which is a tall order. I'm going to take you through some of the things that I think are important for families to understand when they're talking to their doctors or each other or trying to read what's on the internet. And it's probably going to make more questions than it is answers, but we'll be moving along and getting you more educated about your children and their condition. The green one, right? The big green one? Oh, click here. What is an epilepsy syndrome? So there's a lot of pieces to this puzzle. Age of onset, the type of seizure, development, other aspects. And this was put together by a group of experts at the International League Against Epilepsy in 2017, and before that about 10 years, and before that about 10 years. So they continue to modify the names of these syndromes. So you may hear several different ones, as you heard in that autism lecture, that there's always a gradual change in the terminology that doctors use just to keep us on our toes. So I'm going to do a little EEG primer here for everybody. So you're all going to be EEG experts in just 1 minute. So this is a normal EEG for a 4-month-old or about. The way we look at EEGs, this is like a computer screen. You can see it says L, that's the left side of the brain. That's the right side of the brain. And first thing we do is compare one side to the other. Is it about the same? Is it symmetrical? The next thing we do is we look at the front to the back of the EEG. We look for lower voltage, meaning lower waves, and higher frequency, meaning more ups and downs per second in the front of the brain versus the back of the brain. And we'll count those literally with our eyes. We'll go 1, 2, 3, 4, 5, 6. And that can make up a number that we put on the EEG report called the posterior dominant rhythm. So if you've heard somebody say that your child's EEG is slow, it's because we counted those numbers and they were a bit slower or lower than you might expect for their age. And this evolves over time. You're probably looking at this very prominent black stuff over here, which is completely normal. It's actually from the muscle that overlies your skull on the side of the head. You can kind of feel it when you clench your jaw. So that's something that has nothing to do with the brain at all, but is the most prominent thing. And these other little things that we just visually have to zero out when we're looking at EEGs day in and day out. So you can imagine this is something that you don't want to do once every 6 months. This is something you want the person who's reading your child's EEG to do every day, and to read 100 of them every day, so that they have a really good understanding of what is normal and what's not. Now, this is obviously abnormal EEG. Just to point out some of the main aspects there. You guys are experts already. You can look at the symmetry as the first thing. Next thing, you're immediately going to go to the counting the back of the brain, and you can see that it's a bit slower than the previous EEG. And also looking from the front to the back, it looks about the same in the front as it does in the back. So that organization is not normal. These things that look like they would hurt to sit on are called spikes. And those indicate that the brain is firing in an abnormal way, which can lead to seizures. Those are multifocal in multiple areas of the brain, and these are generalized and diffuse or all over the brain at once. So now that you guys are experts in EEG, I can show you this fancy slide, which I think is really helpful for getting into the right ballpark about what syndrome a child might have. So child comes, they start having seizures at whatever age. You look at that EEG background, you can say in between seizures, it's normal. Oops. You can say it's normal, or you can say it's abnormal. And if it's abnormal, does it have those multifocal spikes, or does it have those generalized spikes? And there's some other nuances as well. But basically for SCN2A, there's two main areas that we might think of where on this graph where patients might have an epilepsy syndrome. So either a normal background and have seizures in the neonatal or infantile period, or several of those boxes lower down with multifocal and diffuse spikes with varying degrees of slowing. I'll just put up this slide, which I think is helpful just to emphasize the difference between gain of function, loss of function, and the spectrum between the benign or so-called benign or familial infantile seizures and epileptic encephalopathy. So we're going to be talking about mostly the gain of function as they apply to epilepsy syndromes primarily. So the self-limited familial neonatal infantile seizures was the first SCN2A phenotype. This was the first type of seizures or epilepsy syndrome that was associated with SCN2A. And it's usually in families, but there can be the first one in a family as well, can be new or de novo. Usually the onset is in the neonatal period or up to 7 months old or so. These are seizures without fever, usually focal, and we'll talk about that a little bit more, starting in one area of the brain and possibly spreading. Seizures usually stop by a year of age, and they have normal development, so may go on to have their own children and not have seizures in the future, or some, and pass along the abnormality. So moving on to the more severe end of the spectrum, we'll talk about encephalopathy or developmental and epileptic encephalopathies, and all of the different International League Against Epilepsy syndromes that are listed here. Neonatal, the Ohtahara syndrome or early myoclonic epilepsy. In the infantile period, West syndrome or epilepsy of infancy with migrating focal seizures. And the unspecified developmental and epileptic encephalopathy that we talk a lot about with SCN2A also usually starts in the infantile period. And those can progress to Lennox-Gastaut syndrome, which is a more nonspecific type of epilepsy. And that can be sort of an endpoint. Children will usually evolve from one of these other syndromes into Lennox-Gastaut syndrome rather than starting with Lennox-Gastaut syndrome. So early myoclonic epilepsy and Ohtahara syndrome can be lumped together. Dr. Ohtahara described the distinction between the two very eloquently. But in practical sense and in the clinical sense, they both have an abnormal EEG, as you can see here. Looks abnormal to you. You guys see spikes. You see some asymmetry from one side to the other, and you see slowing. The seizures are usually very difficult to control, and the child will have developmental delay going forward. But the EEG pattern here is called burst suppression. As you can imagine, it's just a descriptive term. You have bursts and then you have suppression or lowering of the voltage. Next syndrome, West syndrome or infantile spasm syndrome. Usually the onset is about 6 months old. Child could have had Ohtahara syndrome before that or start having West syndrome on its own or develop from some other type of epilepsy. Infantile spasms are the main type of seizure. These usually occur in clusters when you're falling asleep or waking up. And they kind of look like a jackknife. The child's head will go forward, the arms will go out. It can be easily missed for colic or some other movement and dismissed by very experienced physicians. Some pediatricians have told me they've never seen a case of infantile spasms, which I find hard to believe, but maybe they didn't realize it was infantile spasms. So if you have any concern about your infant having these sort of repetitive movements, it's a good idea to bring it to the attention of a neurologist. You can rule out the diagnosis pretty quickly with an EEG during wake and sleep. The EEG during a seizure will have this prominent flattening of the EEG, which is called an electrodecrement. And the pattern that you'll be looking for in sleep or in wake and more progressed cases is called hypsarrhythmia. You can see this is very abnormal due to the high voltage and multifocal spikes. And developmental regression is the last piece of that triad. Epilepsy of infancy with migrating focal seizures, usually onset in the infantile period. They have focal seizures, meaning they start on one side, and these seizures move or migrate from one side of the brain to the other, and they have poor developmental outcome typically. And here's just a slide of a typical migrating seizure from a paper that was published, not necessarily for an SCN2A patient. You can see this is compressed to show how the seizure moved from one side of the brain to the other. And here's a developmental and epileptic encephalopathy case that I took care of. A child was seen at a local hospital and kept having these breakthrough seizures with cyanosis, and they would load with this medication called phosphonatonine before they shipped or transported to the main hospital. And the seizures would stop for a couple of days. They think everything was fine and send the child back to the rural hospital region. Eventually, we figured out that was the most effective medication for the patient. Had a relatively normal EEG at 4 months old. You can see the seizure here with that attenuation again and prominent change in the background really can't be missed. The seizure stopped with this sodium channel drug. The diagnosis of SCN2A was made, and the child continued on a different sodium channel drug, carbamazepine, and had some developmental delays, but no seizures going forward. Just to show, this child was relatively on the mild spectrum for both seizures and development. The Lennox-Gastaut syndrome that we talked about before has the triad of multiple seizure types. So basically any seizure type possible can occur in Lennox-Gastaut syndrome. Usually they have multiple in this same period of time. The abnormal EEG I'll show examples of, and they have intellectual disability. This is the slow spike and wave. It's sort of like the hypsarrhythmia has become more organized. And the tonic seizure, which is one of the most common types of seizure, again, looks sort of like the spasm EEG pattern, but with a longer duration. So in wrapping up, I'd just like to emphasize how children might start on this path at any one point. But if it's possible with all these interventions that we're discussing here at this meeting, we might be able to stop this evolution and prevent children from getting Lennox-Gastaut syndrome or their epileptic encephalopathy developing further and causing more developmental delay. So always have hope. Thank you.
Thank you, Dr. Millichap. That was wonderful. I'm sure everybody is thinking of questions. Please write them down. We will have a Q&A session after this. I also appreciate, for someone who's been studying epileptic encephalopathy for years and years and years, you tripped up on that word. It took me 3 years to be able to pronounce it the first time. It's such a hard thing. 15. All right, now we have Dr. Ann Bird, who's going to tell us about she's also from Northwestern. She's going to tell us about our clinical trial readiness study.
Thank you. Also, like Dr. Millichap, I'm formerly from Northwestern, but still have keep maintaining an affiliation. Can you hear me? What? Yeah, okay. And forward is just the green light, right? It's working, the green, okay. Thank you so much for having me here. It's really a pleasure to get an opportunity to address this amazing group and tell you a little bit about the clinical trials readiness study that you've all been participating in, or many of you have been. Go. No? That one, okay. This study is funded by you, the FamilieSCN2A Foundation. We have a really pretty amazing, wonderful collaborative research team. Many of us are here today. Lindsay Evans, Aria Kaiser, Catherine Patel, Amanda Nils, and Erica Anderson, Aaron Kotz, and their apologies, they couldn't make it. But you've just heard from Dr. Keith Kaufman, Jerry Nesbitt's over there, Leah Schust, and I've been the very, very fortunate captain of this incredible group of people. We have expanded to another project, the Instone Project. I'll mention that. And we're so delighted to have Dr. Natasha Ludwig, who just spoke, Dr. Mary Wojnarowski, Cher Chapman, Gabi Conacher, and Jayetta Hecker. It's really been amazing. And we're all here. The end game, as you know, for SCN2A is to have a therapy that substantially improves the lives of people who have SCN2A associated disorders and the lives of their families, maybe even cures the disease. That means scientists have to find the treatment and they have to test it in a whole bunch of preclinical models to show that it's doing what we think it should be doing. But the real rubber hits the road when we demonstrate that it makes a real meaningful improvement in human beings, not in a mouse, not in a cell, but in a human being. This is a problem. These are rare diseases. We don't understand them very well. And the FDA has been issuing a series of guidances for about 10 years now. And they urge pharmaceutical companies, before they do a catawampus through a complex disorder they don't understand, to understand that they should understand first the full range of disease manifestations. Know what it is you're treating. This is really important in the DEEs because while they often involve seizures, SCN2A often involves seizures, it doesn't always. There are plenty who don't have epilepsy. When the seizures occur, they're often pharmacoresistant, but not always. Sometimes they're pretty well controlled, and that makes them very, very hard outcome measures for clinical trials. What we do see pretty much across the board is what has very loosely been termed developmental delay or intellectual disability, and that's been sort of a wastebasket for a whole bunch of very, very specific things that include communication, language, behavior, orthopedic problems, neuromuscular problems, gross and fine motor difficulties, dental, autonomic, sensory, eating, swallowing, vision, endocrine, gastrointestinal, sleep, respiratory, the list goes on. As Keith Kaufman says, pretty much anything in the body can be affected for a variety of reasons. In addition to understanding the full range of disease manifestations, the FDA sort of said, you might not want to go after everything, but you should go after signs and symptoms that are most important to patients, those things that are life-limiting, life-changing. And once you've identified those things, you select your clinical endpoint. It can't just be, well, we're going to work on sort of gross motor. That's actually a very, very big thing. Select a very specific clinical endpoint and then have a very sensitive and specific outcome measure so that you know if you've made a difference. The SCN2A CTRS began last spring. We're working on the one-year follow-up. And I neglected to mention probably the most important part of the team has been the SCN2A family. So let me just stop for a moment. And if you don't mind disclosing, how many of you are in the CTRS? Sure. Oh, wow. Amazing. Thank you. It has just been, yeah, really, thank you. It's just fantastic. Without you, we wouldn't be going anywhere, and you're teaching us so much. We hope to have this done for you by late fall, end of the year at latest. And what we've been doing has been focusing on parent-reported outcomes, not clinical exams. And parent-reported outcomes are important. That's your experience with your child at home on a daily basis, not in an exam room. We've looked at the medical history, epilepsy and seizures. That's all very interesting, but what we've really been focusing in on are functional abilities, communication, behavior, and adaptive behavior. Adaptive behavior is how you use your skills to negotiate independently in the world. It's a little bit different from having a skill. It's can you use your skill? We have had 81 people participate, 81 families participate in the study, including 65 in the actual longitudinal CTRS and another 16 in a more limited one-time survey. About 3/4 come from North America, US and Canada. We have, though, people in South America, Western Europe, Eastern Europe, including one family in the Ukraine, and my hearts go out to them, and I hope they're doing okay. I don't know. Israel heard we were doing this and they said, we're in. They're amazing. We have 4 families in Israel and we have 1 in Australia. So we are across the world. The group that you have been participating in includes a little bit more boys than girls, or males than females. I don't know if that's real. We'll see as we look at other data from the SCN2A communities. The median age at enrollment into our study was 5.4 years. About half of children were between 3.4 and 9.7 years, oldest 29 years, all the way down to about 1.5 months. Most of the young people have a diagnosis of epilepsy, and also about 45%, all those without epilepsy, but also many with epilepsy, have a formal diagnosis of autism, and others have features of autism without a formal diagnosis. I want to talk a little bit about age at onset, because this is really interesting. I think you all know the story, and you heard from Al George, I'm sure, that there's a difference between very, very early onset seizures versus later onset seizures and no seizures at all. And in particular, the gain of function mutations appear to be of neonatal onset if epilepsy occurs. The autism only appears to be mostly loss of function, and then there's some mixed stuff in there. This is the violin plot for the age at onset of seizures. And what you can note, let's see if I can do this, there are an awful lot of kids all the way down there at the bottom. These are neonatal onset. In fact, about 40% of children had onset in the first couple days of life, and the other 60% beyond that, going up to 10 years. There's this huge range. This is really important, as I mentioned, because of that gain of function. So we're all waiting for Al George's group to share back the functional data on your variants so that we can combine the data collaboratively. But I did the phenytoin test, right? Phenytoin is one of the most famous blockers of sodium channel function. And I asked, okay, I've got parents who said, yes, we gave our child phenytoin and it worked really well. And yeah, we gave it and no, it didn't do anything or it made things worse. And I looked at the age at onset of seizures and those who said it worked really well versus didn't. And you can see those who said excellent, whoops, let's go back. Excellent response, all neonatal onset. Not so good response, much broader range and much fewer neonatal. So I'm going to show you a few slides where I will use neonatal onset as a proxy marker of what I think is gain of function and show you a little bit about how these children are different. In terms of neuromuscular concerns, we see a lot of spasticity and dystonia, more in those with neonatal function, neonatal onset, a lot of scoliosis as well. And that's related to the hypotonia that we see, probably the dystonia and some other factors as well. But we see hypotonia throughout. So that's pretty ubiquitous throughout SCN2A disorders. We hear a lot about vision concerns, cortical visual impairment, which is a concept that's been around for a while, but we're talking about it a lot. Very common, especially in the neonatal onset. But if we look at those other things that might be part of CVI, like judging distances, visual motor impairment, impaired depth perception. We see a lot of that as well across the board. The next few slides are going to look at degree of severity in those with the neonatal, later onset, and no epilepsy. And I'm using these offset bar graphs for the first time, and I hope they're effective. You can tell me whether you like them or not. But I want you to focus on that dark bar at the top. This is the group of children who have complete impairment of function. So this is gross motor function, ambulation. Can a child walk for 5 yards in the home independently, with help, or no? And the no, needs a wheelchair, is that dark bar. And you can see that the neonatal onset is much more likely to be impaired. Those with no epilepsy, least likely to be impaired. Hand use. You can see those with neonatal onset do not have even a basic hand grasp, whereas with those with no epilepsy, most of them have a pincer grasp. And the later onset is in between. Communication, though, is pretty much impaired across the board. You heard Natasha Ludwig talk about autism is an impairment in communication, social communication, so we're not surprised by that, but communication across the board is extremely impaired to the point that most children do not communicate effectively, even with their parents and people who are taking care of them every day. Eating safety is really important. A lot of these children have G-tubes. I didn't break out G-tubes separately in this group, but that dark piece at the top are the children with G-tubes or who eat PO but cannot eat safely. Only 5 minutes. Okay, I'm going to hurry. Self-care, not going to go there. We have a lot of concerns in this group. What are we going to use for randomized trial? Well, the typical thing is to go to the outcome measures boutique and pick a great outcomes measure. Okay. The problem is that these are all designed for use in the general population. Very quickly, and I may need an extra minute for this, Christina. Things that are designed for use in the general population are normed to the general population, and things in the general population tend to follow a normal distribution. It's a theoretical mathematical distribution. It looks like this. It has a mean, and the variability in the distribution is quantified by the standard deviation. 68% of the population is within about 1 standard deviation of the mean. If we go out to 2 standard deviations, it's 95%. And if we go out to 3 standard deviations, we have practically everyone, right? 99.7%. And that 0.3% is sort of split between the upper, above, and below. So we would expect about 1.5 people per 1,000 down there. Where are the SCN2A children? Here's a graph just to give you a visual impression of the profile of functional impairment. The purple is the relatively independent, the brown, the can do but needs help, and the green, that greenish color, that's the completely dependent or does not have function. And again, you see the neonates are much worse off than or appear to be worse off than the later onset epilepsy, and the children without epilepsy seem to be still quite impaired, but relatively better off. How could we look at that? Well, a very common thing is to use the Vineland scales of adaptive behavior, very popular measure. Here's what the scores look like. You can see population mean is 100. Here's 3 standard deviations below the mean. There should only be about 0.15% of the population down there, but about 95% of the SCN2A children are in that range. And you can't really appreciate much difference between these groups, certainly not what you're seeing on the radar plots. Part of the problem is that this is a composite measure. It's putting a whole bunch of things together. Questions like community use. How does your child take the bus across town? You're laughing, right? He doesn't, but that's part of the measure. So it's kind of a lot of irrelevant stuff. But so what we can do is get into a very specific piece of the Vineland. So for example, expressive communication. And here's what the expressive standardized scores look like. You can't tell these children apart. They are all at the very bottom of this measure. This is a little hyperbolic, but I'll give you a visual as an example of what's going on here. Imagine you go into a neurology lab, a basic science lab, and they say, we have a hypothesis that neurons in one species are have bigger nuclei than neurons in another species, okay? And you say, great, I'll go test that. I've got my measuring tape. Well, a cell has a nucleus that's usually in the range of about 6 microns in diameter, okay? An inch is about 25,000 microns. All of your cell nuclei are going to be 0.0000000 or whatever inches, right? You can't even see it. And that's what we're doing. We're using the wrong scale in these children. Is there an option? Yeah. There's an alternative way of scoring the Vineland called the growth value scales. And this is what these children look like now, using just same data, but alternative scoring. Same nuclei, but we're not going to use a measuring tape. We're using a electron microscope. And while we're not seeing many differences, we are appreciating that there are differences between the groups, neonatal, et cetera. We do appreciate that there are differences among these children. They are not all down there at the very bottom of the barrel. Here's another way of looking at those data. In purple at the bottom are the actual scores, the standardized scores that we would see in the general population, right? If you were to go out into the school, if you went into a school, you wouldn't see these scores. But by age, you can barely tell the difference across these children. In green, though, you see this alternative scoring, and suddenly it's like, oh, there's variation in this group. Let me just point out a few children, for example, excuse me. These 3 down here all have the exact same standardized score. If we look at the alternative score based on the same input of data, they're different. We can actually tell the difference between them, among them. Furthermore, and this really encourages me, if you look, there's actually a bit of a correlation with age, suggesting that younger children have lower scores. As they get older, they gain skills. And that makes a lot of sense. They don't on the standardized scores. They do on these growth scores. This is not showing that in an individual child, he's changing from year to year, but those data are coming. At least cross-sectionally, we're seeing older children doing better. So I'm very hopeful. We are also adding on the Inchstone study, which is a collaboration with Deep Connections. Gabi Conacher and Jayetta Hecker are here, along with Vega. And this is for those who are at the very bottom of the measurement still, so that we can really dig down and represent all children with SCN2A and other severe forms of DEE. We have 2 neuropsychologists, a neurologist, Dr. Kaufman, qualitative researchers, and many more. And it's just been a neuropsych fest, as I've said. We're using additional measures, some novel measures, and really trying to think outside the box. As I said, it's going on here right now. And I'm so grateful to Leah, to the whole SCN2A Foundation, to all of you for your participation. Stay tuned. We will be bringing you more results in the next few months. Thank you.
All right. We have all of our presenters from this group come back up. And we'll talk very quickly. Let's see, we've got about 15 minutes for a conversation. You guys are gonna have to turn that on, share it. Leah's collecting.
Okay, so while the questions are coming, I'm going to blame my emotional dysregulation on Leah Schust-Myers and Michelle Lewis. Okay. So they ambushed me during lunch to present me with something completely unexpected and incredibly heartfelt, and I couldn't take it. So I have for those of you who this is their first SCN2A meeting, I have given that talk probably half a dozen times since 2019. I have done it every single time with complete emotional composure. But because of these 2 amazing women, I couldn't keep it in this time.
Again, I don't know how to follow these kind of statements, so I'm just going to go. The first question we have is, my son has also been diagnosed with Lennox-Gastaut and/or Dravet. Is there a specific difference? Does it matter? Which one's the most important, and why is it SCN2A? That last part was me editorializing, obviously.
Well, I think either I or any of us could probably take this, but so specifically, I didn't mention Dravet syndrome during my my talk. I considered alluding to it because there have been some papers published that suggest that Dravet syndrome can be caused by SCN2A, but I think that these cases need a lot of scrutiny. My understanding of Dravet syndrome is that it's a clinical syndrome first, which has very specific presentation of seizures. Typically, these kids will come in with very long jerking seizures on one side of the body with a fever. So they might literally have jerking of their arm for 15, 20 minutes longer. And then they'll be sent home from the emergency room with a atypical febrile seizure. That's a strange term that's used a lot in emergency rooms, which doesn't actually mean anything. It's not part of our official nomenclature. And then they'll come in next month with a jerky on the other side. So we call that alternating hemiconvulsions. The child will be otherwise perfectly healthy and normal at that stage, 8 months, 9 months, up to a year. And we'll do an EEG in between these, and it will be normal, and nobody will quite know what it is. Now we know to do genetic testing because it's probably Dravet syndrome. And that child will go on to have other seizure types. It was originally called severe myoclonic epilepsy of infancy. So they start developing little jerks or quick jerks of the body in that second year of life, and their development will usually plateau. There is a spectrum of Dravet syndrome, but that is the most typical presentation. And from my talk, you all know that sounds very, very different from Lennox-Gastaut syndrome. If children with Dravet syndrome are very severe, they may go on to have a similar presentation as Lennox-Gastaut. And we saw Charlotte Dravet in Chicago over 10 years ago. And that's where I think I heard the story of how she was working with Gastaut and Marseille on her dissertation. And they were, back in those days, they were studying children with Lennox-Gastaut syndrome who were living in a home there in Marseille. And she saw the children walking from one building to another, and there was light shimmering through trees. And there were some of the children, not all of them, would start to have these myoclonic jerks or seizures. And she recognized that those children were different. And that's where she found their early history and described severe myoclonic epilepsy of infancy, which was later renamed Dravet syndrome in her honor. I think I got the story right. Dr. Berg probably knows, pretty close.
I think we should.
Dr. Berg's heard it too.
We should probably move on to, I have a full stack here of questions.
Well, I hope that answers the question.
So we have two related questions on autonomic dysfunction. I'm going to answer one real quick. You know what that was? How do we access the info that has already been published on autonomic dysfunction? I think that this is something that the Family Foundation can help with. We're going to put it on the website, and I'm saying the royal we, even though I'm not involved, but I can help. Also, if you can't access a journal article because it's behind what's called a paywall, you have to pay for it. There's a lovely thing called Sci-Hub, sci.hub. It's the best thing out of Russia. It's basically bootleg science. Okay.
I was unaware.
Oh yeah, it's a beautiful thing. When UCSF and the entirety of UCSF was fighting with a publishing company, I just got my stuff from Russia. I don't know what they're tracking, but you know what? Doesn't matter. Okay. If I think my child has autonomic dysfunction, how should I approach my child's neurologist? Because obviously my child's neurologist is not Keith.
So the first thing is, we neurologists are data geeks, right? We're nerds, right? That's why we're neurologists. The thing about neurologists, the old joke about neurologists is we're exceedingly precise, but not very helpful. So that's why, you know,
Have you been talking to my wife?
I was a systems neuroscientist, remember? So that's why I included all the citations, right? And that's why I included all the citations, and the slides are being recorded, because if you look at most of the studies that I cited, they have been published since the last time I gave this talk in person in 2019. So these are all very, very new data, except for the one about the neurotransmitter abnormalities, which I stumbled upon about 10:30 last night.
Related again to autonomic dysfunction, what do we know, if anything, about the non-DEE autonomic dysfunction cases, particularly in loss of function? What do we know if a kid doesn't ever present with a seizure? Can they present with autonomic dysfunction? And is it identical to what you would see with severe epilepsy?
So it's similar presentation, yes. What's interesting is, so far in my N of only a few cases, treatments don't seem to respond the same way, right? So, and this is where we need folks that are doing the basic work, the animal work, to look at, you know, if possible, neurotransmitter systems, metabolomics of neurotransmitter systems, to see, are there differences in gain of function versus loss of function in more metabolomics, things of that nature. Because clinically, my loss of function patients, when I try to treat their autonomic dysfunction like I do my gain of function patients, they do not respond the same way. And I don't have the chemistry to explain why.
Thank you. This is a pretty challenging question here for Dr. Ludwig. We've been told by our SCN2A that our SCN2A child with IDD and autism will stop learning during adolescence. I'm going to editorialize and say whoever told you that should be slapped. Do you concur? I've just editorialized. And does learning continue lifelong?
Yeah, I would agree with your statement.
That they should be slapped.
Yeah, definitely.
Yes. If there are Russians listening.
Oh boy. Yeah, no, I would never put a limit on a child. I think there are so many ways, there's so many therapies and so many strategies to try and support development. And whenever I see a child, I don't ever think about limits. I think about what can we do to get them to the next stage of their development. And so I think it's just talking to the right people, talking to the right rehabilitation team, talking to the right therapy team, right? And making sure that you are collaborating with your therapy team about what your goals are for your child, what your values are, and making sure that your therapy team meets you there. Therapies are a collaborative process. And so make sure that, you advocate for what you want your child to be working on in therapies, and make sure your therapist is aware of that and appreciates that and values that as well. Yeah, that's what I would say.
Wonderful, wonderful. These are three somewhat related questions, but also a very large topic that'll probably take another 15 hours to talk about. So let me go through three and then you guys get to answer. My child is almost 6 and the spasms have never stopped. Hers are opening arms instead of the typical crunching ones. Have you ever heard of this? Of course. If there are other people in the room that can offer support or common effects, seek each other out. Can you tell us a little bit about ESIS, CSWS, and SCN2A? And lastly, can you talk about the spikes on the EEG versus the actual seizures? Do you ever treat just the spikes? And are there specific EEG patterns or epilepsy syndromes that are very important to know, or is the etiology more of the focus? Oh my gosh, that's the entirety of epileptology, I think, there in those three questions. Go ahead, John.
I'll be here all night, so find me after the show. No, I think I forgot the first question.
Oh, me too.
Oh, I'm sorry. It was so having uncontrolled epileptic spasms. So after the age of 2, we tend to refer to them not as infantile spasms, but epileptic spasms. And infantile spasms are a type of epileptic spasm in my mind. Yes, this can occur in some children. If they're a bit longer and not so much in clusters, the spasms may have evolved to tonic seizures at that point, or brief tonic seizures. So yes, it is possible. As looking at the EEG and the patient, really a spasm is almost like the beginning of or a very, very, very brief tonic seizure. And then the second question was ESUS. Oh, so I didn't mention CSWS and ESUS. That's continuous spike wave in sleep, or electrical status epilepticus in sleep. This is an epilepsy syndrome as well, and it has not quite, in my mind, well defined features. It is seen in many different many different etiologies. So it can be seen with SCN2A, can be seen with no known cause, can be seen with structural abnormalities of the brain like strokes. And this is having a lot of spikes when you go to sleep, as you can imagine, electrical status epilepticus in sleep. So basically the spikes that we saw become continuous, like every second there's a spike. And this is traditionally associated with a otherwise normal child who suddenly has some speech regression, and it was described as a cause of this speech regression. In our children who have epilepsy and have otherwise abnormal EEGs, we have to really differentiate or find that clinical part. Did the child's development regress associated with the EEG change, and then we might target it with certain treatments. But I think in a patient with SCN2A who already has a DE, it could be difficult to parse out that change, especially in the development. And then,
Can I just say something about that?
Yeah.
The ESUS is really important, that EEG pattern. And we used to think of it as being extremely rare, but people are starting to recognize it more and more. And it's not that it's suddenly happening more and more, but I think epileptologists are picking up on it more and more. And in my work across many different rare disease organizations, it is getting reported, and it's starting to become the focus of specific therapies for ESUS. So keep it in mind. Make sure that you've explored that with your child's neurologist. There are concerns sometimes when children have a sudden change in their behavior, they're suddenly more spaced out, they're losing language, even if they don't have a lot, they're losing communication. Really explore that. He can give you better medical advice on that than I can, but do have that in mind. It's not ultra common, but we have several people in the CTRS who have reported ESUS as a finding for their children.
And in keeping with the CTRS, I'm going to change topics quite a little bit. There's a question about a correlation between the intake of dairy products and a change in seizure frequency. And I'm going to expand that to a general question of, are we looking at dietary trends within the CTRS? First off, dairy, but just in general, and are there correlations, observations that you've noted?
Yeah, we have not done that for a very specific reason, that we're trying to do a really good job with a set of measures. And those of you in the CTRS, it's kind of a lot of work, right? You know, it's like an hour and a half Vineland every 6 months or so, and then all those forms you have to fill out. So we worked very closely with your board to define what would be the scope of the CTRS, and really stick to that and not try to do everything and then, you know, do a bad job doing a lot. We'd really want to do a good job doing what was needed, really focus on the goals.
Oh, that's interesting. That was the Russians. So here we have a question about a child with a loss of function, SCN2A, with autism, late onset epilepsy after 5 years old. Would sodium channel blocker, general class of drugs, be appropriate for that child or avoided? The answer is avoided.
In general, we would probably avoid it.
Mm-hmm. And which drug would be the best?
I think it would
That's the
depend
harder
on
part.
what the seizure type is, and we have to really tailor our choice of medications based on what that seizure type
So I
is
would-
at that moment.
Can I say that the person who asked that question seek John out right after this?
Sure.
Good.
I'll be here all night.
You'll be here all night. The last question actually also is for you, John. You mentioned at the end of the progression is Lennox-Gastaut. And that is something that you're working very hard to avoid as much as possible. What about the families that are already there? What approaches would you provide for them? Are there research opportunities or developments in that field that help people that are in that position already?
Excellent. So there's a Lennox-Gastaut Foundation, and they have a website, and there you can find lots of information about Lennox-Gastaut and clinical trials that are specifically for Lennox-Gastaut. They may not be specific for SCN2A, but they would be, your child might be eligible for trials related to their diagnosis of Lennox-Gastaut syndrome. And I think just keep trying and work with your epileptologist, or if you haven't seen an epileptologist, get a second opinion with an epileptologist to make sure that you're doing everything you can for their seizures, but then also develop the rest of the team for all of the other things that go along with the developmental delay.
I just wanted to mention that Lennox-Gastaut syndrome is a very serious issue for SCN2A. I didn't put the slide up there, but about a third of the group with epilepsy reported LGS as a diagnosis. So it's not uncommon at all. It's an extremely serious form of epilepsy. And as Dr. Millichap said, the Lennox-Gastaut Syndrome Foundation provides another community that's a syndromic community. You have a gene-based community, and they are doing some really interesting work. Lennox-Gastaut syndrome it's like a rhythm gets set up in the developing brain. It's a network problem, and they're actually starting to look at some potential therapies for that. And they're not drugs, they're not ASOs or anything like that, but they're actually electrical stimulation patterns. And I think of it, how we have those noise canceling earbuds.
Mhm.
It's kind of like noise canceling earbuds for your brain. It calms that rhythm down by countering it. So if you are interested, I would really recommend getting in touch with that organization as well, and see if they have something to offer to you. They're a very welcoming organization. I know Leah's good friends with their director. Christine founded the organization, so you're kind of in the same boat here.
Wonderful.
Same community.
So Keith said at the beginning of this, he whispered to me, and I'm going to out you now, is this is what happens when you do it because you love it, not because it pays the bills. I want to thank all of these people up here for doing what they love. I hope your bills are being paid too, but thank you all. Can we give them a round of applause, please? And we're not doing any more photos or anything right now. We're coming back at 3:30. We're going to start calling you in a few seconds before that for the last full session of the afternoon. Thank you.